Okay, so I gave you guys pretty thorough lectures on Blackboard, so I'm not going to go through all this again, but just a couple of things that I wanted to kind of point out. When we're getting ready to scan somebody, there's a couple of things that we need to make sure that we have first. We need to make sure that the correct person initiated the exam. Like, we can't take orders just from a nurse over the phone. Someone needs to initiate that scan if your script is incorrect. So a verbal order needs to come from a physician. We can take an order from a PA. We can take an order from who else can we take an order from? Nurse practitioner. Yeah, we just can't take it from like the secretary at a doctor's office can't change the script or change the exam. So we need to make sure that the correct person initiates it. Before we scan a patient too, we also need to change them. We need to make sure that they're properly changed, that any kind of metallic objects are out of the way. If we're scanning their abdomen, we need to make sure that there's no piercings or anything that they need to take out. If they have personal belongings with them, especially real personal stuff like their teeth or like expensive jewelry, sometimes it's best just to have them bring it into the room with them and put it in a container on the counter, and then when they're done, you can give that right back to them. Not that I don't trust lockers at a outpatient center, but when you're talking about things that are really like their teeth and glasses and things like that, sometimes it's just best to let them bring them into the room with them. Before we scan a patient, we also need to take three things. We need to take a clinical history because we need to find out why they're there. We need to take a medical history because we need to know what their medical background is. And we need to take an allergy history in case we need to inject them. We need to make sure that we know if they have any allergies. The next thing we're going to do is need to select a protocol. Have you guys all gotten familiar with the protocol books at clinical? Okay, so every site should have a protocol book to use. That should be kind of like your guide as to how you're going to set the scan up. You don't just want to go off on your own and set it up the way you think you should set it up. I mean, people have sat down, and especially with advanced radiology, I know they have a committee that gets together that puts together these protocols. So sometimes there's very specific things that need to be done for certain patients. And you'll talk much more about that when you guys get to scanning procedures. The room always needs to be prepped. It's always nice to bring a patient in to the table paper's already changed, either the head holder or the foot holder's already on. Either way, if you draw the contrast up when the patient's in there or you draw it up ahead of time, sometimes it's nice to draw it up when the patient's in there because they know you've put a clean syringe on, that you've drawn it up, you've checked it, you've gotten all the air out of the line. Not that they're paying attention to that, but that's something I would pay attention to if I was a patient or any other medical person would pay attention to. Okay, so I talked a lot about communicating with patients, so I'm not going to go back through that again. But I was going to show you a little video in the beginning, but I talked too much. I didn't want to show it because it's like 10 minutes. But has anybody ever seen that video where kids are throwing a basketball around and then the gorilla walks through the middle? And then like half of the people, if I showed it to you, half of you, I'll say, did you see the gorilla? And half the people that I showed that to would be like, no, I didn't see a gorilla. And it clearly walks right through the video. So I always kind of show that at the beginning because it's kind of called unintentional blindness, meaning that you failed to see something because you were focused on something else. And that kind of happens sometimes when you're talking to patients. You're talking to the patient and they're talking to you, but you're not really listening because something's going on over here and you hear another exam's being ordered and you got a stat, and you totally missed what the patient said. So you hurry up and jot down what you think they said. But one thing that we all need to remember is you may be the only person that ever talks to that patient. No one else is talking to that patient but you. So if they give you an important piece of information and you miss it because you were distracted and something happens to the patient, that could come back on you. So you always need to make sure that you're listening to your patient, not just half listening, but really listening to your patient, not halfway in the middle. No, we're not doing that, we're doing this. Oh, get that. Yeah, you don't want to do that. You don't want to be that tech that half listens to their patient and you miss something, because it's very easy, and you guys are going to see, and that being a CT tech is way more responsibility than it was just being a diagnostic tech, because you're, potentially injecting someone with something. Patients are much more worse shape sometimes coming to CT. So we need to make sure that we're always paying attention and that we're taking a good history to make sure that we get all the information, because whatever you write down on there is all the radiologist is going to get as well. So any little piece of extra information or anywhere that you can let him focus, show him where his, the radiologist's focus should be, is going to help him make a diagnosis. Does everybody understand that? Okay. I wanted to show you this. Have any of you guys ever heard of the ACR appropriateness criteria? Yeah, it's a website that you can go to that was established by physicians, radiologists, but it's guidelines to help referring physicians figure out what's the best diagnostic test to do. Because sometimes maybe PAs or referring physicians order the incorrect test. For example, patient has swelling in their neck, so they order a C-spine. Well, what did they really mean to order? Soft tissue neck, right. So you need to just make sure that, or they order, what else do they incorrectly order? They'll order a CT of the pelvis for ovarian cyst. Well, CT is not good for gynecologic stuff. If it's big and huge and we can see it, but if not, we're not the best test for that. Ultrasound's the best test for that. So anyway, there's appropriateness criteria. So you just go to the ACR, you click on the appropriateness criteria, and a sheet comes up like this with tons and tons of protocols in it. And you can see the rating scale down here. 1, 2, 3 means usually not appropriate. 4, 5, 6 means it may be appropriate, and 7, 8, 9 is usually appropriate. So if you look up here, acute chest pain, suspected aortic dissection. So we want to look for anything that has a 7, 8, or 9. So 9 would be a chest x-ray to look to see if there's mediastinal widening. That's a norm, that sounds appropriate to order. CTA of the chest and abdomen with IV contrast, again, a 9, appropriate exam to order. But something that might not be appropriate, echocardiography, transthoracic resting test. That's probably not appropriate test. Or aortography, chest and abdomen, probably not appropriate. MRA of the chest, a 7. So you want to, this is kind of what referring physicians sometimes will go to when they're trying to figure out what diagnostic test is the best test to order. That's just showing you a protocol. Okay, a little bit about assessing the patient. So tonight we're gonna talk about normal vital signs. We're not gonna take each other's temperature because I would hope that everybody could take a temperature. We're not gonna do that tonight, but we will practice taking a pulse rate. We will practice taking a respiratory rate, and we will practice taking a blood pressure. And I can guarantee you on the registry or on tests that I give you, I may sometimes ask you, what's a normal systolic pressure for a child? And I'm going to give you ranges, and you could open 10 books and there's going to be 10 different ranges. So you have to make sure that you look at the most appropriate one that I give you, because people say, well, that's not what you had on the slide, but the registry's not going to have what I have on the slide either, because I don't know where they're getting their sources from. So you just have to make sure that you know a general range of numbers for these vital signs. Okay, taking a clinical history. So the thing that you guys need to start doing when you're talking to a patient is developing your own routine. And I'm going to continue to say that because you guys don't have a routine yet. You're watching everybody else's routine, and then you have to come up with McKenna's way to do it. So you're going to take, I really like the way Christina does this, and then you're going to go to another site, and you're going to say, man, I like the way that she said that. And then you're going to go to another site. So you're going to kind of take a little bit from everybody, and then you're going to have to come up with your own way of asking questions. And when I was working clinically, I said the same thing to every patient every time. I had a list in my head, I knew exactly the order that I was going to go in, and then I never missed anything. Now, I might say it differently to an elderly person. I might have to say it a little slower or use other examples because they don't understand. Or a child, I might have to say it a little bit differently. But basically, I'm always asking the same questions in the same order to get my answers. The same thing when you're explaining the exam to the patient. You lay the patient down on the table. You explain to them, I'm going to inject you with contrast. And then what are some other things you might say to them? What's it going to make them feel like? What's it going to make it feel? Right. So you're going to say, I'm going to get ready to inject you with this contrast. It's going to give you a very warm, flush feeling. You might feel it from the back of your throat all the way down into your pelvis. That's totally normal. Then I'm going to leave the room. If for any reason you need me for anything, just yell, wave your arm. I'll be right back in. I've said that to every single patient that I scanned. And then as soon as the scan was done, Immediately you get up out of the chair and you go in and you check on them. Okay? That's the way I did it, but you might have something else that you might say. When you're taking a clinical history, you always want to ask them why they're there, what brings you to the office today. Patients that are like repeaters are going to get very tired and annoyed with people asking them the same questions over and over again, particularly patients that are cancer follow-ups. You always want to ask them, look at their old history sheet. Whatever you can get from their old history sheet, copy it onto your new history sheet. And then you're going to say to them, I've looked at your old history sheet. Tell me if anything's changed since the last time you've been here. I understand that you were diagnosed with cancer at such and such date. I understand that you had surgery, I understand that you have radiation and chemotherapy. I understand that you're allergic to this, 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 and this. Has anything changed since the last time you were here? Have you developed any new allergies? Have you had any new surgeries? Have you had any new treatments? Do you have any new symptoms? So that way they don't have to kind of rehash their whole cancer diagnosis to you over again. So it's always good to look at an old history sheet and kind of copy over, especially for those repeaters. But if they're brand new, you got to go through the whole spiel about why you're there, where's your pain. Of course, we're always going to ask LMP. We're going to make sure that they prepped. If they had to drink something, we're going to make sure that they drank what they were supposed to. Have they had any other imaging tests recently? Any other imaging tests for this same complaint that they have? Maybe they had a chest x-ray and now they're there for a chest CT. So you always want to make sure you try to find that old report so that the radiologist has a lot of information to kind of go on. Have they had any recent barium studies? That becomes important because you guys know what barium looks like on CT. It's way too dense for us. It looks like, fireworks. We have to make sure that all that old GI or BE barium is out before we can scan their abdomen. I went through this a lot in the online thing, so I'm not going to go through it again, but you really have to make sure that you localize where their pain is. Where's your pain? How long have you had it? Does anything make it worse? Does anything make it better? Does anything alleviate it? So you want to ask all those questions. Then we're going to go on to a medical history. We need to find out if they have any major medical problems. And usually what I say to a patient is, do you have any major medical problems, heart, lung, or kidneys? And they'll tell you. Then, do you have high blood pressure? And the patient usually says no. And then you say, do you take blood pressure medication? And then they say yes. So they have high blood pressure, but patients don't understand that. So sometimes you have to ask a question with a question when you're questioning somebody. Diabetes. Do you have diabetes? Are you insulin dependent or do you take oral medications? If they take oral medications, we have to find out what the name of that medication is, right? We're going to talk a lot more about metformin and stuff during our contrast class. But we need to find out what medication they're taking. Suppose the patient doesn't know the name of the medication they're taking. Then what do you do? Like we have to find, what if it's an outpatient? Elderly people should always have a list of their medications. I preach this to my parents. You always have that in your purse, Mom. You have to have a list of your medications. Or if a family member's there, you can ask a family member. If a family member's not there, maybe they can call home and ask a family member. The other trick that I've tried too is call the pharmacy where they get their prescriptions filled. They're probably not supposed to tell you because it's probably a HIPAA violation, but they will tell you, the patient's here. We need to know what the name of the medication is they take for diabetes, and usually they can help you out with that. Have you ever been diagnosed with cancer anywhere? Where? Have you had treatment? Have you had surgery for it? Have you had any surgeries in relation to where we're scanning? If we're doing an abdomen, I don't think we need to know that they had their tonsils removed and all that, but anything in their abdomen. Have you had any surgeries? No. Do you still have your appendix? Do you still have your gallbladder? Honey, I had my appendix out years ago. Like, they don't count that, but that's a surgery. So you have to write that down, appendix, gallbladder. Do you still have your uterus and ovaries? Sometimes you have to say it specifically like that. Don't just say hysterectomy because they'll say yes. Just say, do you still have your uterus and your ovaries? And most women will know that. And then you want to document, your assessment should start as soon as you introduce yourself to the patient. You should already be checking them out. What do they look like? Do they have a rash anywhere? Do they have trouble breathing? Are they diaphoretic? Are they sweating? You just want to have a good baseline assessment in case the patient has an issue while you're scanning them. At least the radiologist comes in, you're like, no, he was like that before we started. Like, where did that red rash come from on his arm? No, he had that before we started. That's not because of the injection. So always get a good baseline assessment of your patient. It's always our responsibility to explain the procedure to the patient, tell them how long it's going to be, if we're going to use contrast or not, and we have to go through our whole spiel about contrast, finding out about their allergies, if they've ever been injected before, what's expected of the patient. Always empty their bladder before you start. Unless they're for an IVU, then of course we can't empty their bladder because we need their bladder full. But the worst thing is to get a patient on the table, laying down, arms up, and they have to pee. And you want if you don't, when they get that warm sensation, they might pee themselves. So always the last thing I would do when I get a patient out of the dressing room, do you need to use the restroom before we start? It only takes 2 minutes to let the patient run in and out of the restroom, and it could save you a big headache. We always want to reassure the patient that we're going to do the best scan that we can do, but we never want to tell them everything's going to be fine. You're not going to have a reaction to this. You didn't have a reaction last time, because we don't know that. Patient could have had 10 scans perfectly fine with no reaction and then react. Patients can develop allergies. Particularly spring and summer when the histamines are up, you're going to find you're going to have more reactions than ever. So you just want to make sure that you just reassure them, but don't tell them that everything's going to be fine, because we don't know that everything's going to be fine. And then when the exam's over, you're going to tell them drink plenty of fluids, tell them that their physician should get a report, in about 2 days' time. Usually that's when physicians get a report. Patients always want to know when their results are going to be, ready. Okay, checking the chart. We're always going to check the chart for the order. If it's an inpatient, we're always going to check lab values, right? I went over these in the presentation online, but you guys should know what these are. I don't expect you to know every lab test, but you should know what a CBC is. What's a CBC? Everybody listen to my lecture? CBC, complete blood count. What's in the complete blood count? Red blood cells, white blood cells, ESR, the sedimentation rate. In the ESR, too, is the amylase and lipase. People that have a high, elevated amylase and lipase are more apt to have pancreatitis. So I always would check the amylase and lipase just before I scanned a patient. The blood chemistry is where the BUN and creatinine is. That's where you want to check for that. Sometimes when you call an office and you're trying to get lab work, the secretaries don't know where to look. And if you say, I don't see a creatinine, you say, check the blood chemistry panel. It's there. So sometimes they need to know that. We always need to check renal function to make sure that's normal. Some places are going to use a creatinine. Some places are going to use a GFR. I don't know if everybody's gone to total GFR yet. You guys can let me know that. We never checked a GFR in CT when I worked in CT. We always just checked creatinine, but I think they're changing that. MR strictly only checks a GFR. So you just need to make sure that you know which each of those are and normal readings for those. Blood clotting assessments become important. Doing interventional things. You're at St. Joe. Have you been involved in any interventional stuff? Okay, so they want to check PT, PTT, platelets. Want to make sure that it's safe before you do any interventional stuff. What's a D-dimer? Anybody? What's a D-dimer? It's for blood clots. So if somebody has an elevated D-dimer, it's suspicious for them to have a clot. We don't know where the clot is, but usually patients who come for a PE study will have an elevated D-dimer. So that's another blood test. Little bit about electrocardiography. I don't think we need to know a lot about this, but you should know what the P, QRS, and T waves are for. You can look that over when you get home. I'm going to post this PowerPoint online for you guys. I think I have it on there already. Maybe I just don't have it open yet. But Janice from Plumtree filled this out for me to show me like things that specific ways that she fills this out. So you can look this over to kind of see what's involved in taking a good clinical history and kind of how things should be written out on this sheet. This is the part that the patient fills out about their allergy history. We should always ask the patient, do you have asthma or hay fever? Do you use an inhaler? Do you use an inhaler daily? Some people only use it in the spring. Some people only use it when they have an issue. Some people with asthma use it daily, 3 times a day. So you want to find that out. definitely always want to find out if they have diabetes, if they take medication for it, any heart, lung, or kidney problems, any allergies at all. And don't just say, do you have any allergies? You want to say, are you allergic to anything? Any foods, any medications? They're the most important things too. When they tell you they had an allergy, what should be your very next question? What happens to you? Yes. Oh, I get nauseous. Well, I don't really care about if you get nauseous, but if your throat swells and your tongue swells, that worries me. Nausea, that just could be because they have a weak stomach or they took their medicine without eating anything. But I want to know, are you allergic to anything? Has anything ever given you anaphylaxis? Has your tongue ever swelled? Has your throat ever swelled? Have you ever had trouble breathing? What's the one food you should always ask patients? No, we don't care about shellfish anymore. Shellfish poses no more higher reaction than any other If a patient tells you that they're allergic to shellfish and they tell you they've had, their throat swelled and their tongue swelled, that would worry me. But that doesn't worry me any more than if they said the same thing happened when they took sulfa. Like any kind of anaphylaxis worries me. But if just because a patient's allergic to shellfish doesn't mean they can't be injected. Mm-mm. It is a fruit. A fruit? It's a fruit, yep. Oh. Strawberries. Strawberries is the closest thing to contrast. If a patient tells you they're allergic to strawberries, that should throw up a gigantic red flag immediately. I posted a lecture for you guys in the contrast week from Elliot Fishman from Hopkins, and he talks a lot about a strawberry reaction. So when you get into week 4, is it week 4? Contrast. In one of the videos, it's, and I'm really like a nerd, but he gives a Facebook Live every, I think it was today, I think it's every Thursday at 12 noon. Elliot Fishman does a Facebook Live, and you can type in questions and stuff to him. And sometimes the topic I don't really care about. Sometimes he talks about things that are more administrative stuff, but sometimes he'll talk a lot about CT, specific CT stuff. And one week he talked about contrast and contrast injections, and I recorded it, which is probably illegal, but I recorded it down here using our Snagit or whatever, and I posted it for you guys because it's really good, and he talks about reactions, and he talks a lot about, he talked about strawberries in that. So listen to that next week when you get to the contrast. Okay, so I'm going to go through these pretty quickly because I want to get to venipuncture, and then I want everybody to practice sticking the arms. But specific exams, you should ask specific questions. And one thing that you might want to do, and I'm not going to make this for you, but you could make it in your book, is, under chest, like write down things that you should be asking when someone has a chest CT. Write down the things that you should ask when someone's having an abdominal CT. For a chest, are you a smoker? How many packs a day do you smoke? If they say they quit, how long ago did you quit? Have you ever been exposed to asbestos? That's an important thing to ask. Are you having any short of breath? Are you having any chest pain? If they say I have a cough, is it productive or is it dry? That's a good thing to ask so you can let the radiologist know. Also, remember, ask women about any breast surgeries because we can see breast tissue on chest CT. So we just want to, if something shows up weird in there, the radiologist is going to be like, what the heck's going on? But if you have on your sheet history of, right lumpectomy, he's going to be like, oh, I know what that is. It's just from her breast surgery. So that's a good thing to ask women. Abdomen and pelvis, again, all the symptoms that they tell you, whether they have pain, diarrhea, constipation, nausea, vomiting, any weight loss, how much, over how long of a period of time. Did they have any trauma? Again, surgeries, appendix, gallbladder, any bowel surgeries, any female surgeries, all that you want to ask when you're questioning a patient for abdomen and pelvis. Extremities, we don't do a lot of extremities, but you're going to get them from time to time. Any pain, where, how long, any injuries, any surgeries, any bruising, any swelling, any dislocations. That's an important question that MR always has to ask if there's been any dislocations. Spine, cervical, lumbar, or thoracic. You want to ask about pain, of course, any numbness or tingling in your arms or legs, Was this pain a result of an injury? If they've had any surgeries, and what level were their surgeries, if they know what it is. Some patients will know right away. Soft tissue neck. Again, any pain, how long? Do you feel any lumps in your neck? If they feel a lump, what should we do? Put a BB on it. Yep, we should always mark that if they feel a lump. Any difficulty swallowing? Always remember to ask if they still have their tonsils and adenoids. That's a good question to ask when you're doing a soft tissue neck. IACs or temporal bones. Anybody had any experience with this yet? They're complicated a little bit, especially the reconstructions. But again, any pain, how long, any drainage from the ear, any hearing loss. Have they taken any antibiotics for this ear symptoms that they're having? Head. We do tons of heads. We should be asking any pain, headaches, any specific area that they're having pain in, any vision changes, any dizziness, any syncopal episodes, any trauma. Those are things you should ask for a head. Sinuses. Anybody done sinuses yet? Are they doing axial or are they doing coronal sinuses?
They were doing coronal.
So they actually put the patient coronal?
We did one of them that way.
That's the way we always did them when I scanned, but now they just put them axial and then reconstruct them coronally. But you don't get a true, what?
Air fluid level.
Right, if you do them axial. You only get that if you do them coronally. So always remember when you're doing sinuses, take out any earrings, hairpins, hearing aids, all that needs to come out. You should ask them about if they've had any surgeries, any congestion, postnasal drip. I'm not going to go through all these. How to take an allergy history. Again, have you ever had a contrast reaction? Have you ever had contrast before, and have you ever had a reaction? Having a prior reaction is the number one risk factor for having a reaction if you've had one previously. So we always want to make sure, and we want to make sure that when they're telling us about a reaction, that it's really to the kind of contrast that we're going to use. Patients get all confused. They had contrast at their eye doctors. They injected it in their eye. Well, that's different than us. If they don't understand the contrast that we're using, sometimes you have to say, it's the same kind of contrast you had if you ever had a test to check your kidneys. If you ever had a heart catheterization where they put a needle in your groin and injected dye. Oh, yeah, I had that before. So then it kind of, it's that contrast where you get that warm, funny feeling. Oh, I've had that. Yes.
Is the MRI contrast different than?
Yes.
Okay.
Totally different.
Okay.
Totally different. So, are you allergic to anything? Have you ever had a contrast reaction before? If they say they had a reaction, then you need to find out what it was. What kind of reaction did you have? Any foods or medicines? Ask the strawberry question. Bee stings, too, is another biggie that you want to make sure that you ask if they're allergic to bee stings. If they tell you they're allergic to any foods or medications, you always want to jot down what happens to them, if they broke out in a couple of hives, versus if they tongue swelled and they had trouble breathing. Have they ever been hospitalized for their reaction? This is just about metformin. Some places probably have patients refrain from taking it. Some places are probably not doing that anymore. According to the ACR, patients that fall into category 1, that's patients with no evidence of any kind of kidney injury or with a GFR greater than 30, there's no need to discontinue their metformin. They can just take their medicine as usual. Patients that fall into category 2 that take metformin that are known to have acute kidney injury or severe chronic kidney disease or have a GFR of less than 30, they should refrain from taking their medicine for 48 hours. Their creatinine should be checked again prior to starting it, and then they can restart it. So I think advanced radiology, do they still have patients, do you know?
She mentions like stage 1 or stage 2.
Okay, so they.
She does the GFR. So like when we're doing the creatinine like together, we'll do so like the creatinine was like 0.6, BUN was like 72, and then she would do a slash in like stage 1 or stage 2. That's all she writes.
For metformin patients?
For
Okay.
any like kind of patient, really, she just does stage 1 or
Okay.
stage 2.
Because just remember, metformin's that medication that, metformin, that the biggest risk factor with patients taking metformin is that they can develop lactic acidosis. And patients that develop lactic acidosis and have some kind of kidney issues, they can't clear it, so that makes the lactic acidosis worse. So patients that are on metformin, that's already a risk factor for lactic acidosis, if we inject them with contrast and it hurts their kidneys, then we could really put them in danger. So years ago, we used patients that were on metformin, we would just say, after they're injected with contrast, they have to stay off of it for 2 days and then get a repeat creatinine, and then they can go back on it. But since then, over the last probably 5 years, the ACR has gone to this like category 1, category 2, where if you're category 1, you don't have to stay off of your metformin. If you fall into category 2, the recommendation is that you stay off of it. So every site and every facility is probably going to treat metformin patients a little differently, but just so you guys know, this is what the ACR is saying, and for us, the ACR is kind of our, should I say Bible? I don't know, Bible. Okay, when you're taking your history and when you bring that in next week, it's perfectly fine to use abbreviations, but you also want to always make sure that you spell words correctly too. You never want to like spell something incorrectly on your history sheet, because you never know when this sheet's going to come back around again. Not this sheet, but a history sheet. A couple years ago, Rick was sometimes they ask us to do this. I've never done it. I've offered to do it, and then they don't call me. But you could be an expert witness for CT, and Rick was one time, and it was about a patient that had to infiltrate. And they pulled that, the history sheet was right there in court, and Rick had to look it over. And luckily, the person that filled out the sheet, when the infiltrate happened, like they had everything documented, like exactly what it looked like, how it happened. So you always want to make sure that you fill out your history sheets correctly, because you never know when that might come back around again to bite you. So you just want to make sure you do it correctly each time. You want to spell words correctly. You want to make sure that you asked all the questions. You want to make sure that if you make a mistake, that you just put one line through it, your initials, and then don't scratch through it. You always want to make sure you use, I don't think you have to use a blue versus a black, but you should use blue or black, not red or any crazy color like that. You should always make sure that if there's a question to be asked and you asked it and the answer is no, you put no, or you at least put a circle with a line through it. So at least I know that you asked that. Sometimes if you put nothing, it looks like maybe you skipped over that question. So you just want to make sure you thoroughly fill out your history sheets. These are just a bunch of abbreviations you can use, so you don't have to spell things out, because sometimes they don't give you a lot of room in that history area to put stuff. And then this is kind of just like everything we have to do before we scan a patient. So there's a lot of stuff that we have to do before we actually can start scanning that patient. Okay, let's move on a little bit to a little bit about venipuncture. Now, unfortunately, you guys probably are not going to be able to stick patients at your clinical facilities. If you can, great, do it. If they're going to allow you, do it as much as you can. But I know the advanced sites won't let you stick. But hopefully, maybe when you get to the hospital, what do you think about St. Joe? Will they let you?
I don't know if he was kidding or not, but he was like, "I'll let you do the next
Yeah,
one." So
yeah.
Like, okay.
I mean, it's perfectly in our scope of practice. We're RTRs. It's in our scope of practice to do it. But advanced radiology, just because of liability and stuff, they don't let students stick. So these mannequin arms are really the only practice you're going to get. But when you get your real CT job, they're going to train you how to do it. But it's unfortunate that they're not letting you, because it's a really important skill that you guys can see that, we're almost sticking every single patient. So it is an important skill to have. And it's the one complaint that I get with MR and CT graduates of mine. They'll be like, "Oh, they're having such a hard time sticking patients." I'm like, "I know, because you didn't let them practice for 6 months, and now you're training them for 2 weeks, and you're wanting them to fly on their own, and they can't because they haven't had enough practice." So anyway, this is going to be our venipuncture night where you guys can practice. I would just make sure that when the techs are sticking, that you're just in there watching. Like, watch everybody's technique. Take little pieces of what each person does, because you might like the way one person holds the needle or stretches the skin, or how they set up their equipment or whatever. So just, try to learn as best you can, just observing them. The same thing with loading the injector. I know a lot of places probably are not going to allow you to load the injector, but if you get the opportunity to load the injector, you guys should be doing that. Of course, with supervision, but it's an important skill as well. Okay, so venipuncture. So the one thing that I always tell people is it's always important, if you're going to stick a patient, that you always have all your equipment ready. You don't want to look like a ding-dong and be missing something, have to scream out to your coworker to get you something, and you're trying to use your teeth to open something. Just want to make sure you have everything that you need. You need a tourniquet, you need a connector to put on the end so that it can connect from the IV to the tubing from the injector. You want to have an alcohol prep pad so you can clean the area. You want to have tape so you can secure it. Of course, you want to have your IV catheter. You also want to have a pair of gloves to wear. So you want to have all your equipment together. We always use a tourniquet. We want to slow down the venous without affecting the arterial because we want to plump those veins up. One way that we can do that is by having them pump their arm or, rub it. We don't have to smack it. You just rub it to kind of try to increase circulation in that area. You never want to leave your tourniquet on for too long. One reason is that it's extremely uncomfortable for patients. The other reason is that if you're taking blood out, like you're taking a sample of blood, hemoconcentration can occur where the blood gets stagnant in that area because you've had the tourniquet on for so long, and lab results can be, incorrect. So we're not actually taking anything out. We're putting contrast in, but I don't know, you just might want to keep that in mind when you have a tourniquet on. Okay, so the IV catheter. So if you guys have had any experience with these, you know that most of them are needleless now, so there's really, it's very difficult nowadays to stick yourself with a needle because they have these needleless systems. So first of all, on the outside of the package, this is an Insight AutoGuard, which a lot of facilities use. We're not going to be using those tonight. We're going to be using a little bit different kind tonight. On the packaging, it's going to tell you what the gauge is. The gauge tells you what?
Size.
The size, right? So the smaller the size, what? The bigger the needle, right? So remember, gauge is kind of backwards. Whereas if you're using a catheter for like a voiding cystogram, they're usually measured in French. So it's the opposite way. So you just remember the gauge, the smaller the number, the bigger the bore, or the bigger the needle. It's also going to tell you how long the flexible catheter is. It's not going to tell you how long the needle is. It's going to tell you how long the catheter is that you're advancing. Because remember, it's a dual system. It's a needle, and inside of the needle is a flexible catheter. So we stick the patient with the needle, and then we advance the catheter kind of off, and then we take the needle out. So depending on the vein, sometimes patients, 1-inch catheter is too long. If they have really bad veins, you might want to go to a smaller size length catheter. But usually 1 inch is fine. On this catheter, back here's the safety barrel. This is kind of where when you retract the needle, it goes for this particular system. There's an activation button, so once you've advanced the catheter off, you push that button and it retracts the needle back into the safety barrel. There's a push tab here, so when you go to stick, when you get into the vein, you push the catheter off of the needle, so you use that push tab. There's a flash chamber right here. Most needles will have a flash chamber. When you're in the vein, you'll see a little bit of flash of blood. That way you know that you're in, so that you can advance off. If you get no flash, doesn't necessarily mean you're not in, depending on the needle system type. And these ones we're using tonight, Rick said he couldn't get a flashback on it, but typically you'll get a flashback which lets you know that you're in the vein. What else is on here? This is just a different kind of needle on this side. This is after the activation. The needle's back here. Here's the catheter off. Just a little bit more close up. Here's the bevel of the needle. You always want to stick the patient with what? Bevel up. Always bevel up. Shaft of the needle. Here's the hub. The size of the lumen, which is the opening, tells you what the gauge of your needle is. Butterflies, I'm not a big fan of using butterflies in CT. I worry that if the patient has a reaction, that's not going to hold up if they need to transport the patient. Plus, some people that use a butterfly, they put the butterfly in, inject the patient, and they take it right out. I'm like, what are you doing? Like, sometimes reactions don't happen right away. Usually reactions will happen pretty quickly, but that makes me very nervous using a butterfly, but you will see people using them at the sites, especially if it's a person with poor veins. They might say, oh, let's use a butterfly. I would just be extremely careful. Make sure you leave that keep everything attached. Even take the syringe that's still attached and just tape it to the patient's arm until, you're sure that you're out of like a reaction time frame, that it's been a good 5 minutes and they're fine and nothing's happened. They use butterflies in MR all the time, and it makes me extremely nervous because although they have less reactions than us, they can still have a reaction. But if you have a angiocath in, you can hook up fluids or push meds, and it travels well if the patient has to go to the hospital. So I'm not a big fan of butterfly, but you will see them being used. We talked about the gauge. One thing we're going to talk about when we talk about contrast in a couple of weeks, and we talk about the power injector, is needles being pressure rated. And just something for you guys to watch when you're at clinical these next couple of weeks before we talk about the power injector. I want you guys to really pay attention to the power injector these next couple of weeks. When you're injecting a patient, I want you to look at the pressure setting that's on there. I want you to watch as the contrast is going in to see what the pressure is. And we'll talk a lot more about these needles being pressure rated and why that's important during our contrast week. But this is the insert from a 18 to 22 gauge needle. It tells you that they're suitable for use with power injectors rated for a maximum of 300 psi. So we just want to make sure that we're not going above the recommendation from the manufacturer with pressure. We'll talk about that in a couple weeks. Okay, so selecting a site for injection. So we always want to examine both arms very carefully. Who's the best person to ask which arm you should use? Right, because the patient knows their veins better than anybody. They've been stuck a gazillion times probably, and even though you see like a nice juicy vein in their antecubital, they might say, honey, nobody ever gets anything out of there. But you think you're going to be the one to do it, and then you stick them and nothing comes. You can't get it in. So you always want to make sure that you listen to your patient. They'll direct you as to where's a good vein to use. Most commonly, we'll use this antecubital. Sometimes we'll use this vein. What's this vein called? It's this vein right here. Goes all the way up. It's on the thumb side. I'm not going to tell you. You guys will. That could be a quiz question this week, so you better check all those veins out and make sure you know which is which. Oh, this is going to tell you. Darn it. Okay, so this is the cephalic on the thumb side here. So it starts, this might be a vein that if I couldn't get a vein here, this might be the next place that I look. This is always like a nice juicy vein right here. And it kind of runs all the way up. Veins on the inside, I wouldn't recommend these basilic veins, but usually the antecubital or that cephalic. Red flags. Okay, so where wouldn't we want to stick a patient? We wouldn't want to stick a patient on the side where they had a mastectomy. Why don't we want to do that? Don't everybody answer at one time. Why wouldn't we want to do that? Because this is important. We're injecting something into the patient. Good, because especially if they had lymph node dissection, if we inject them and their lymph system doesn't drain correctly and all that contrast sits here, they're going to end up getting like lymphedema and an infection. So we never want to use the side where they had a mastectomy. And patients will usually tell you right away, like, you can't use that side. They told me don't let anybody use that side for anything. They really shouldn't get blood drawn from that side. They shouldn't get blood pressure taken from that side. And they certainly shouldn't get contrast injected on that side. We never want to inject in a shunt. A shunt is for dialysis patients where they put a vein and artery together. Never want to inject through that. We never want to take someone's arm and, if they're contracted, you never want to like force that down and try to put a angiocath in there. You want to try to avoid the side that patients have had a stroke on because they have impaired circulation on that side. You'll want to try to avoid the side that's bruised, tattooed, scarred, burned. Burned patients have impaired circulation. So all of those areas, if possible, you want to try to avoid when you're sticking someone. Again, the steps involved, always going to make sure we have the correct patient, gather our necessary equipment, wash our hands, put our gloves on, put the tourniquet on, do our site selection, figure out where we're going to stick. Always trust your finger more than your eyes. Although you don't see a vein, you might feel one, so you want to trust your fingers more than your eyes. Never perform a blind stick. Everybody has an antecubital, so you just don't want to just prep that area and say, I know it's in there, so I'm just going to try to stick it. You never want to just blindly try to do a venipuncture stick. If that vein doesn't plump up, a couple things you can do. You can try to warm the area with warm compress. You can have them put their arm in a downward position, kind of see if gravity will help you plump it up once you have the tourniquet on. Tap it. Sometimes you might have the tourniquet either too tight or too loose, so just sometimes adjusting your tourniquet can help to get that vein plumped up. When we clean in a circular motion from inside to out. Okay, we don't just take the gauze pad and just rub it on there. We want to go inside to out. We either want to let it air dry or we want to take a clean 2x2 and just wipe it one time. You don't want to leave like a puddle of alcohol on there, because when you stick a patient, it's going to burn. Yeah, it's going to burn a little bit. Let's see. So what we're going to do is we're going to figure out what vein we're going to stick. We're going to anchor the vein, meaning we're going to make that skin nice and taut, right? Make the skin. Anchor the vein helps to prevent the vein from rolling away from you. That's one risk that when you're doing venipuncture is that you're going to go to stick it and the vein's going to roll away. So you really want to try to hold it with your non-dominant hand so that you don't run the risk of the vein rolling. You're going to, and this is a little bit different than when you stick patients to get blood, you're going to have a very low angle for venipuncture, putting an angiocath in. A really low angle, with the bevel up, you're going to go in, you're going to observe flashback. Once you have flashback, you're going to advance the catheter just another hair, and then you're almost going to have the whole needle and everything almost parallel now with the arm. Before threading, you're going to advance the unit just a little bit. Like I said, you just want to make sure that you're fully in the vein. And then you want to advance the catheter off of the stylet. The stylet is the needle. It's just another name for the needle. Then you want to advance that catheter all the way to the skin surface, okay? Once you start advancing, if you run into resistance, don't force that. You also don't want to pull the catheter back on top of the needle. You don't want to, once you've pushed it off, you can't put it back on, because then you run the risk of the needle going through the catheter, and then you don't want to do that. So you have to be confident. Once you push it off, you've made the commitment to go. If you hit resistance, you might just need to take it totally out and then start over again. You don't want to try to pull the needle back into the catheter. You don't want to get into that. So once you've advanced it all the way up, you're going to stabilize the catheter hub. You're going to press the retract button if it's that kind of system. These needles we're using tonight are not, but you're going to, before you retract that though, what are you going to need to do? Because once you take this stylet out, once you take the needle out, what's going to happen? Blood's going to come gushing out of there, right? While this needle's in there, blood's not going to come out. So as soon as you take that out, blood's going to come gushing out. So what do you need to do to avoid that? Pressure. You have to put pressure right up here. Lots of pressure. Push the button, take the needle out, have your hook up ready, hook it up. You are all going to have a blood bath at least one time. It's going to happen until you get good at it. Trust me, I've had many early in my career and I learned my lesson, so you need to make sure that you put good pressure on that. You're going to need some kind of, I wonder if Jess is out there. Are you sitting in the dark? Tell her to come down. Okay, so we need to have some kind of connector to put on the end of that angiocath. Something has to go on the end of here that's compatible with our tubing from the injector. So usually you're going to see these clave connectors. Looks like this. It has a male end and a female end. It has this silicone seal. That's usually what we put on the end of the angiocath. Then, once we get that all in place, we're going to flush it. When we go to flush, what's the first thing we're going to do? We're going to hook it up, pull back, right? We're going to pull back because we want to see if we have blood, get blood back. If we get blood back, then we know we're still in the vein. Then you're going to flush it. Are we going to gingerly flush it? No, we want to mimic what the injector is going to do because we want to make sure that this angiocath that we put in is going to be able to withstand whatever you're injecting, 2 cc's per second, 3 cc's per second, 4 cc's per second. What does Mercy inject at?
That's a great question.
Say they're doing a CTA study. What do they inject at? I bet you they inject like up 4 or 5, don't they? Check that out this week. Yeah, check out to this week. Really pay attention this week to the power injector, the flow settings.
Yeah, I feel
'Cause-
like I see 1.0, 2.5, but that might be like
Oh, that's really.
the
I bet you they inject at a very high, because they have like a state-of-the-art scanner there, like a 300 slice or something.
that could be something like not.
So I bet you when they do CTA, what about Franklin?
3.5 or 4.
3.5 or 4 for CTA of the head or neck or something like that? Or a PE study, same
For
thing?
PE, yeah.
Okay.
For anything else, it just depends. It could be, I've seen as low as 1 to as high as 2.5 or 3.
Okay. We're going to talk a lot when we talk about contrast about flow rates and why it's so important to use the flow rate that the protocol calls for. Because you're going to find that people are going to get nervous and they're going to adjust that flow rate because they're afraid that their needle's not going to hold up. But if you're afraid that your needle's not going to hold up, you need to take it out and put another one in. Because studies call for 3 and 4 and 5 cc's per second for a reason. And we'll talk more about that when we talk about contrast. But anyway, you want to flush it like kind of hard because you want to 3, 4, 5 cc's per second. You want to make sure that it's going to be able to withstand. If you're not sure, get another saline syringe, hook it back, and flush it again. Just make sure that you flush it well. And if it's an existing catheter, like the patient comes down from the floor, you really want to check it because that's one that you didn't put in. So you want to check the gauge of it, make sure it flushes well, make sure you get good, when you pull back, make sure you get good blood back. Once we get everything in place, we want to tape it securely. Couple things about, like I was just talking about, people that come down with catheters already. We just want to make sure that we flush them properly to verify the patency. If patients come down from the floor with medications running, we can't just stop medications because we need to for the exam. We need to make sure it's okay. Yes?
How do you know the gauge size on an inpatient unless you check the chart?
You can check the chart. Sometimes you can just tell by the color of it. Like you might get good at just, pink is like small and blue is 22, and you might just be able to tell by just the color of it. But it should definitely say in the chart what the gauge is. Yeah, so you want to make sure that you ask if you need to stop medications from running, particularly if patients are on heparin. You should stop that while you're injecting contrast and then start that back up again when it's over. And you want to get permission to do that. You always want to flush post the injection. I don't know if everybody does that, but that's what you're supposed to do. You're supposed to flush before you're supposed to flush before an injection, and you're supposed to flush after an injection. Central lines are okay to use for injections. You have to be very careful if you're using the power injector. You want to make sure it's a power central line or a power port, like a portacath. Some portacaths are not power ports, so you can hand inject only through them, but you can't power inject. So you just want to check those and make sure. PICC lines too, you can have a power PICC or just a regular PICC. So you want to make sure if you're going to power inject through it that it's a power PICC. That means that it's designed to withstand at least 300 psi of pressure. So you want to make sure you don't want to ever power inject through a catheter that's not designed for a power injection because the end of it could, tear off, or piece of it could tear and get in the patient. Just you want to make sure that if you're injecting through a central line, a porta cath, a PICC line, anything like that, you want to double check and make sure that they're able to be power injected through. How about dialysis catheters? Never inject through them. Can't inject through a dialysis catheter, ever. Okay. Any questions about that?